1 in 100 babies are born with some sort of a structural heart defect.
Okay.
Some might require some intervention earlier in the age. Some might just get resolved. There's a window which is slightly open, and there's an air draft which keeps coming in and keeps opening the windows up and down.
Okay.
Right? You want to stop that air draft, so you put a clip across. So that is technically what a MitraClip procedure is. It's not about adding years to life, it's about adding
Life to years.
Life to years.
Yeah.
I have one more relatively younger patient, like a 45-year-old gentleman, repeated heart failure, had a MitraClip procedure done, and 6 months later, he sent me a picture of a holiday from Russia.
Wow.
We've moved away from cracking open the ribs to doing something, in 45 minutes. So, it just keeps getting better and better. No vapes, no hookah, no smoking. For a cardiologist, that's the worst nightmare.
Hi, I'm Jagu and welcome back to the Good Doctors podcast by Zynova Shalby Hospital. Most people hear heart treatment and instantly picture big surgeries, scars, and months of recovery. But here's the thing, a lot of heart problems today can be fixed without even opening the chest. That means smaller procedures, faster recoveries, and in some cases, a whole new lease of life. In this episode, I'm sitting down with Dr. Rushab Parikh, who is at the front line of these breakthroughs. We're exploring how modern heart care is saving lives without the fear of big surgeries. So let's get right into it. Dr. Parikh, thank you so much for doing this with us. Welcome to the Good Doctors podcast.
Thank you, Jagu.
Now, doctor, let me ask you this. We're going to talk about structural heart disease. When we say heart disease, we think artery mein blockage hai. But structural heart disease is a whole different issue, as it were. Can you break that down for us so that we know what areas we're going to discuss? What parts of the heart does it affect?
So broadly, imagine the heart as a house with 4 rooms.
Okay.
The plumbing is what the arteries are.
Okay.
That's where we look for the blockages.
Yes.
Structural heart and structural heart diseases comprises of things if there's a problem with the walls, with the doors, the windows. So that is if there's a hole in the heart, right? So that's a hole in the wall.
Sure.
Or if there's a stuck valve, that's like a door that is stuck. Or if there's a leaking valve, so that's like a window which leaks. So it is more like a problem with the architecture of the heart and not just the plumbing. So that is what structural heart would be.
Heart ka structure, ghar ka structure is a good comparison to have. That gives me perspective right away.
Yep.
So these structural heart problems, and we're differentiating clearly from other regular heart problems, is this something that one is born with, or can one develop it in time? Because I've heard of child being born with a hole in the heart, but can that happen both ways?
So it's both. So 1 in 100 babies are born with some sort of a structural heart defect.
Okay.
Some might require some intervention earlier in the age. Some might just get resolved, requires no treatment. With age, due to certain infections, the lifestyle changes, certain genetic predisposition of the patient, they might develop certain structural heart diseases at a later age. So it's kind of a mix of both. So you could either be born with it or you can acquire it at a later age.
So, slightly odd question. Is one more prone to risk than the other? I mean, if you're born with it, is it a riskier element than if it just develops?
Not really. I mean, it does vary as to what kind of a defect or a problem that the patient has. So, I mean, every issue has its own certain way of dealing with it and a different solution. So, it depends as to what it is. So, I mean, we can't compare one problem to the other. It just depends on what kind of treatment is required at what point in life.
So, I want to come to symptoms. The thumb rules that we work with is chest pain, you climb a flight of stairs and you're panting and you've run out of breath, or pain running down the left arm. Those are those regular symbols that one looks for. But if it comes to structural heart diseases or issues, are the symptoms different? Should I be looking out for something else? Or should I be testing upfront for something else?
Yeah. So with cardiology, we have cardinal symptoms.
Okay.
Breathlessness, like rightly as you said, is one of the most important. So if you're walking around and you feel a shortness of breath, that is one of the biggest symptom that you can come across with. That could be associated with your feet getting swollen, like swelling in your feet. Chest pain is the second cardinal symptom. So you can have some excruciating pain. You feel like there's a heavy weight which has been kept on your chest. That is the second. There could be certain fainting episodes. Right? That is again very important. That means that the heart is not able to pump enough blood out, and that is why you could have like a fainting episode. So that is also important. As per it, sometimes certain diseases, the patient can be completely asymptomatic. That's why it's important that you visit a doctor frequently. Sometimes a doctor might just pick up like a murmur, which is like an abnormal heart sound, and then refer you to a cardiologist. And then on further investigating, you might find out that there is some problem with the patient. So I would say that anyone who's probably above 50, should get themselves routinely tested and make sure that there's nothing going on, because a lot of times symptoms they develop very late, but the signs are something which you can pick up quicker.
No, I can imagine. But your point is right. Then above a certain age, whether it's 30, 40, 50, and that's true for different ailments as you go along. But with the heart, you're saying over 50, you test one way or the other, even if you're feeling fit and fine.
For sure.
Annually?
Annually.
Okay. Or has it come down to now once every 6 months? These things change. That's why it's better to ask.
It changes as per the preference of the doctor also sometimes. So
Fair enough. So, look, heart ailments we've been dealing with for decades and decades, and I know technology has improved, and I want to come to the modern technology that now goes into it. Before, when you had heart problem, the first thing you thought was open heart surgery.
Yeah.
I mean, literally, even if it was needed or not, that's the first thing that came into your head.
Correct.
But now I'm hearing about procedures like TAVI, TMVR. Those are almost non-invasive. Can you explain those to us? What is that technology or those medical procedures?
That's a very interesting question. So, TAVI, and TMVR, they're fairly newer procedures. I would say fairly newer. So initially, whenever there was a problem, if a door of a house needs replacing, you would cut open through the roof and go in and get the door changed.
Okay.
But now what we do is we go through the plumbing and we take a new valve and put it in place of a valve which is not functioning.
Fair.
So I mean, we go in through the arteries of your leg, right? Like we take a catheter, the valve, we go in and then we replace it. So I mean, it's less of a hassle. You don't need to crack open the chest every time. And these are the options with technology as and how it's advancing have become available, and we are doing them very frequently now. So
okay. Now, when we say minimally invasive, what does that mean for a patient? So I already caught it's not a big cut and you're not cracking open ribs to get to the heart.
Yeah.
Net impact is what? Is recovery faster? Is it cheaper? Is there more chance of success? What does that mean from a patient point of view?
So minimally invasive is pretty much everything. That means less pain.
Okay.
No scar, as you said.
Okay.
Faster recovery, definitely.
Okay.
A smoother recovery. I mean, certain TAVI patients, we send them home in just 2 days.
Wow,
so that's quite quick. I would not exactly call it cheaper, but more effective also.
Okay.
I mean, that's where we are at. I mean,
So there are many plus points to this from a recovery point of view, and also from a longevity point of view. These surgeries are like a TAVI is as good as an open heart surgery in terms of how much time it gives the patient going ahead. Is that fair to assume?
Yes, so it is equivocal to
Okay.
a surgery.
Okay.
I mean, that's where we are at. I mean, you need to have the right patient selection for the right procedure,
Okay.
and it should be done with the right team. That
Fair.
gives you the most optimal results, and that just comes with time, and also it is catered to each patient in their own individual way. So every problem addresses a specific solution, and that's how it is.
So I want to explore this TAVI thing a little, TAVI TMVR a little further.
Yeah.
Even within cardiology, that's a specialization, isn't it? You want a surgeon who is specialized, studied in that field to be doing a TAVI surgery or a TMVR surgery. Is that fair to assume? It's not any cardiologist that can do it. An expert has to be called in.
True. So with the valve replacements, so TAVI and TMVR fall under valve replacement, minimally invasive valve replacement surgeries. So out here, we change the entire heart valve without an open heart surgery, as I mentioned before. It requires some amount of training and expertise. Now, because it's a relatively newer procedure, not everyone is trained to do it. So we always work in teams, right? And it's the team which goes in and does this procedure to optimize better result for the patient.
Fair.
You know, nowadays with the advent of these procedures, the numbers also going up. These procedures have started into medical colleges and everywhere elsewhere. So the newer generation of doctors are sort of getting exposed to it.
Okay.
But to achieve a certain amount of expertise, it does take some time and training.
Fair enough. Was TAVI something that was prescribed more for older patients, but now is becoming more generic? Is there some truth in what I'm saying?
Classically, yes, TAVI started off as a last-term resort for patients, for old, fragile patients where we could not offer an open heart surgery. And, I mean, those patients, if they don't get the TAVI, they're going to kick the bucket for sure.
Wow,
Right?
okay. Huh.
So that's where we started off from.
So it's it was a last
It
resort.
was
surgery.
a last
Okay.
resort. That was high-risk cases.
I see.
Over time, we moved on to moderate risk. Today, we've gone on to low risk group, and we have certain large studies coming in from all around the world that the TAVI patients do as well as the surgical patients, even in a low risk group.
Okay. So
it's
younger,
in a
less
in a
blockages,
relatively younger.
less valve issues.
Correct.
I'm using layman terms, but
Yeah.
is that?
So it is a valve surgery, so you
Okay.
can't have less valve issues. But we're now doing TAVIs in a relatively younger population,
Okay.
in a lower risk group,
Okay.
and we're able to produce results as good as of what we get from surgery.
Okay.
So there's a big transition from high risk patients to a relatively younger low risk patient. So we're covering the entire spectrum now.
Okay. The other thing I hear about is something called the MitraClip. Am I pronouncing that properly?
Yeah. Yep.
What does that do? What situations do we have to consider that versus any other type of surgery or procedure?
Correct. I think the easiest way to explain is we go back to the house.
Okay.
There's a window which is slightly open, and there's an air draft which keeps coming in and keeps opening the windows up and down.
Okay.
Right? You want to stop that air draft, so you put a clip across. So that is technically what a MitraClip procedure is. So there's a leaky valve where there's a lot of blood which is supposed to go forward is going back. So we go in and we literally put a clip out there. It looks like a clothespin also. We just clip it up and boom, done.
Okay. Again, minimally invasive.
Again, minimally invasive. We go through the groin and no scar, no recovery time. It's quite quick.
On a more philosophical level, sometimes these surgeries are more about improving the condition of the patient than curing them.
Yeah.
Is that so? There is no 100% solution sometimes because the case has deteriorated to that point.
Correct.
Do these surgeries come in handy then, or do we have to look at one
Yes.
full-on procedure?
So like for MitraClip, MitraClip has become like a mainstay in heart failure patients.
Okay.
Heart failure patient is the one who has to keep getting admitted to the hospital over and over again because they have breathlessness, and this is primarily due to a leaky valve, right? So the MitraClip procedure, what it does is it reduces the leak and it reduces the number of admissions to a hospital. So it significantly reduces the morbidity for a patient,
Fair.
and they can have a much better life. I mean, we might probably not, add years to a life.
Okay.
But, we definitely add life to whatever years they have with procedures like these, So
That's
that
an excellent
really,
way to put it. Yeah.
that
Quality
really
of life
helps.
improves.
The quality of
for what
life
is left.
drastically improves.
Okay, fantastic.
Yeah.
Now, Dr. Parikh, let me ask you this. There's another element that I've heard of. Somebody, a patient goes into a hospital with an unexplained stroke. Now, these are, of course, you rush to the hospital and there is a diagnosis of PFO. One has never heard of this before. It's an unexplained reason why there is a stroke. What is this PFO and how is it a problem?
Right.
Because it's stroke and then now we're talking heart and then we're talking something unexplained.
Correct.
How does that work?
So there are certain causes of a stroke which are related to the heart.
Okay.
PFO being one of those big reasons.
Okay.
Now, a PFO is like a flap-like structure which is present between the top two chambers of your heart. That is present in everyone when you're a fetus, right? When you're in your mother's womb. After birth, it typically closes down.
Okay.
Now, in 1 in 4, this does not ever close down, right?
1 in 4.
Yes.
That's
so
a pretty high
that's
ratio.
25% of the population, it does not close down. However,
This PFO, the PFO and in layman's terms, hole in the heart is the same thing?
technically it could be a hole in the heart.
Okay.
So yes, so it's like a hole in a heart.
Okay.
But a hole in a heart could be a lot more other things, but this is
Okay.
one of those.
Okay, got it.
Now, with the PFO, right, as I mentioned, in 1 in 4, it does not close down.
Okay.
Most of these people would have a normal life without any consequence. In a few of them, right, if there is a blood clot which goes in from the right side of the heart to the left side, right, probably a blood clot in a vein in your leg or something like that, then this patient could have a stroke, right? And
Okay.
if screened correctly, if you find a PFO, you can just close the PFO down. It's a relatively a simple fix.
Okay.
And the patient, we can ensure that does not have a similar episode again ever in their life.
Okay.
Now, typically a PFO is detected in a patient, in a younger patient who comes in with an unexplained stroke. I mean, you don't expect a stroke in a young patient. I mean,
Exactly
why did
right.
this patient have a
Yeah,
stroke?
yeah.
And that's when we start looking for it. And PFO is one of the first things that we typically look for.
Okay, so young patient, unexplained stroke, the first thing the cardiologist will do is assume that we need to figure what happened here. Now, how does one test for this? There's something called the bubble contrast test.
Yes.
How do you even know that, okay, this is what I want to test for? Is it just one of the battery of tests that is done? How does that work?
So, again, moving to a previous question, like a young patient, unexplained stroke, we always want to do the bubble contrast test. A bubble contrast test is very interesting. We just mix some air into normal saline.
Okay.
We inject it in the vein, and at that time, we're doing a 2D echo, that is the sonography of your heart, and we're looking for those air bubbles leaking from the right side of the heart to the left side. So if
I
the
see.
air bubble moves in from the right to the left, that means that there is a connection out there which still
Fair.
exists.
Fair.
And if positive, then we go ahead and, as I mentioned earlier, just close it.
Okay. So I'm just going back to the earlier point, which is astounding me that as fetuses, we're all born with PFO.
Yeah.
1 in 4 don't close.
Yeah.
But as a layperson, I don't hear of 1 in 4 people having a problem with this.
Correct.
So there's enough of us going through life, 25% of us going through life with this potential hole in the heart, but it's never a problem. It
Yeah.
boils down to whether there will be a clot and whether that clot will travel in a
Correct.
particular direction that one needs to worry about. Are those cases rare?
So we don't need to screen everyone for this.
Okay.
Uh, However, in a younger patient with a stroke, as high as 40% of those turn out with a PFO. So I mean,
Okay.
it is important.
Okay.
But as a routine screen for a PFO is not really required.
Fair.
Because 3 in 4, so 75% might not even have a problem.
Fair enough.
So
Fair enough.
it's not really needed.
Okay. And then there's this LAAC.
Yeah.
It helps with people who are suffering from atrial fibrillation.
Right.
Now, sometimes one gets away just with blood thinners, but sometimes this procedure is recommended.
Correct.
What is this procedure? How does it help beyond regular medication?
So this is the other stroke prevention procedure in cardiology.
Okay.
Now, atrial fibrillation is the commonest arrhythmia of the heart. So arrhythmia means an abnormal beating of your heart.
Which shows on the ECG.
Which shows on the ECG. And
Okay.
atrial fibrillation is the commonest one amongst all of them.
Okay.
Right? Now, every patient of atrial fibrillation is put on a blood thinner, because with atrial fibrillation, what happens is we have a pouch in the heart called the left atrial appendage, or the LAA, where there is blood clot which happens,
Okay.
especially in atrial fibrillation patient. So the blood thinner takes care of that. It makes sure that there's no blood clot in that pouch. Now, despite of the blood thinners, we have patients who come with a stroke, right? Or we have patients.
They've already been taking blood thinners.
They've already been taking blood
I
thinners,
see.
but still have a stroke.
Okay.
Right?
Okay.
That means that the blood thinner is not working effectively into that pouch.
Sure.
Or we have patients who present with bleeding because of the blood thinners.
Okay. Yes.
Right? So
yes.
that means that it's dangerous to give blood thinners to these patients.
Sometimes literally from the nose or something
From the
could
nose,
randomly
the
happen.
patient could have a brain hemorrhage,
Oh,
could
okay.
have any bleeding
Sure.
anywhere in the body is possible, right? So unexpected bleeding or an unexpected stroke despite of the blood thinners, these are the patients where we go in and we close that pouch where the blood clot normally forms.
Okay.
So by doing that, we make sure that the incidence of stroke reduces drastically,
Fair
so that we can safely switch off the patient of those blood thinners, which normally we cannot. So that is where this procedure comes in.
Okay.
So again, it becomes like a stroke prevention kind of a procedure. So the PFOs and the left atrial appendage closures, I mean, these two closures are quite essential to prevent strokes from a cardiology point of view.
Okay. But that's a call that the doctor specifically has to make, that this is the procedure we're going to do because we want to get this patient off thinners.
Correct.
Okay.
Yeah.
Now, let me come to what this does for us from a post-surgery net effect point of view. Heart problems, they're unfortunately becoming more and more prevalent. But you must have so many case studies where it is not about the big fat open heart surgery and multiple bypasses and things like that, but procedures like this, minimally invasive, more technologically advanced, newer as it were, I want to say. But you must have stories about how this has helped patients, how this has improved quality of life. And you used a very interesting line. It wasn't
It's not about adding years to life, it's about adding
life to years.
Life to years.
Yeah, perfect.
I mean,
Perfect.
it
Yeah,
just
that's
came
a
up.
fabulous line. That's a fabulous line.
Yeah.
But I'm sure there are. Tell us about some case studies that you've seen.
So,
More
I mean,
complicated, the better.
I know of, like, recently, I mean, there was an 84-year-old gentleman came in for a TAVI. He couldn't walk 10 steps, to go to the washroom. I mean, he would be like, he's getting breathless. He'd have to take a break. I feel like, I'm climbing Mount Everest. It's that difficult. We got his
Had he
TAVI
had
done.
any treatment before?
So he was on medical management, on medical treatment.
Okay.
But he was never diagnosed with aortic stenosis, for which a TAVI is done.
Okay.
Till we did that. And then he was admitted for that procedure. We did the TAVI. 2 days later, we see him in the corridor walking around, sipping on chai. I mean, just 2 days down. I mean, it's just fantastic. So, I mean, it's really nice to see when the patient recovers that fast. And at that age, you want to give them the best quality of life.
Absolutely.
I mean, I have one more relatively younger patient, like a 45-year-old gentleman. repeated heart failure, had a MitraClip procedure done, and 6 months later, like he sent me a picture of a holiday from Russia.
Wow.
So I mean, he went on a holiday with family. So
Fair.
I mean, it did work.
No,
So,
absolutely. Absolutely. He
mean-
should have taken you on that holiday, in all honesty.
So,
So
yes.
you make an interesting point. 2 days, and then somebody who is taking an international flight and having, well, okay, it's a holiday, it's not strenuous, but
Yeah.
you're walking, you're visiting places. There's a lot of activity on that holiday within 6 months. With these newer procedures, what kind of recovery time are we talking about? Are we saying days, weeks, months?
Okay, so as compared to traditional surgery, of course, the recovery is much quicker because, we're not going through and cutting open the chest, pulling the ribs apart. So the recovery from the post-surgical point of view as compared to that is much quicker, and it might vary, right? Certain procedures, the recovery is quite quick. As I said, I mean, 2 to 3 days, the patient starts feeling better. Certain procedures, over time, over a week or a few months. It also depends on what other comorbidities the patient has, like how bad a diabetic is it. Typically, a lot of these patients are in the elderly age group, so they would have a lot of different comorbidities. So it's not just the cardiac issue that we're dealing with.
Sure.
So it depends, varies from patient to patient. But if you purely look at it from the improvement in the cardiology point of view, it depends on the type of procedure that we've done.
Fair.
And how fast does the recovery take place. So.
But what is blowing my mind is that we're talking about an 84-year-old patient who was up and about in 48 hours.
Yeah.
I mean, that's literally where I'm coming from. I mean, it can happen that fast.
Yes.
I mean, coughs and colds take longer to go, in all honesty. So, but I want to use the example of an uncle of mine. I say this in jest, but it's not meant to be that funny also because he makes jokes of it. He's had multiple heart issues where the standing joke is that if he feels something, he calls his doctor and he says, "Do stent le aana." I mean, those are the jokes that he makes. Now, why have these issues happened? Genetic plus lifestyle, all of that. But his thing has also been, you do a surgery, 10 years you don't have to worry, which is a good thing, which is a good positive thing to have in your mind. Positivity, just the mental positiveness plays a part in this. But is that true? Because the surgery is not a get out of jail free card in Monopoly,
So I mean, again, I would like to put it like, we fix the hardware, right?
Okay.
But the software still needs some work.
Fair.
So that is
Okay.
your lifestyle. I
Okay.
mean, if you have high blood pressure, if you have diabetes, if you have any of those other comorbidities, you still need to take care of them. You need to
Sure.
eat right. You need
Yes.
to exercise well.
Correct.
I mean, those things will never go away.
Mutton biryani is not the solution.
Mutton biryani is
It's
not the
correct,
solution.
Correct. Okay.
Maybe you might have it one-off days. A cheat meal is fine.
Fair.
But yeah.
Okay.
But
No,
you
no.
need to take care of the other things as well.
No, of course, no doubt. I mean, that's obvious and logical, but sometimes it's almost a relief कि ये problem था, the problem has gone, अब छूट है. Now we can go to town. It's a mental psychology more than it is a health thing. But you have to be careful about stuff like this because
gotta
you
be
don't want a
careful. I
repeat
mean-
performance by any stretch.
I mean, we can never guarantee 100% results.
Fair.
I mean, doing the procedure right is our biggest takeaway. So once we're done with that,
Fair.
then it's the patient's responsibility to take care as well, right? It goes both ways.
Yes.
It can't always be just a unilateral effort. So I mean, they've got to equally take care and make sure that their systems keep running for a longer time. So
Absolutely right. No, and those are absolutely fair words. I want to ask you this. Technology has moved ahead so much. Literally, like when we're talking TAVI, for example, or the MitraClip, for example, these were things that were not there a decade, 2 decades ago. 10 years from now, where do you see technology? And more importantly, what do you see the impact of that technology being?
10 years from now, better devices,
Okay.
newer therapies,
Okay.
with the introduction of AI, I mean, quicker diagnosis, streamlining the treatment. I mean, it all keeps getting better. I mean, as and how technology matures, I think it gets more accessible. I mean, if you look at what it was 15 years ago to now, everyone has a smartphone today.
Yes.
Right? It's definitely become much more accessible than what it was. So, I mean, with time, technology is going to get accessible. I mean, the number of procedures, these specialized procedures are increasing in tier 2, tier 3 cities. You know, it is getting more and more accessible. Affordability, it's become much more affordable than what it was earlier. You know, so I mean, that's also becoming better. So I mean, with time, it's going to become more accessible, and I'm sure it's going to get better. And the results are also going to get better, because we're going to have more experience. We're going to have more data as to what the outcomes are and everything, you know. So it just keeps getting better with time. That's the beauty of technology, and that is exactly we're at the precipice of you know, something which is wonderful. We've moved away from cracking open the ribs to doing something you know, in 45 minutes, you know. So I mean, it just keeps getting better and better.
How you raised an interesting point. I just wanted to explore that a little bit further. AI, I mean, it's all over the place. Enough people are discussing it. We're reading about it. Books are being written. In the medical sphere, or in the cardiology sphere, if you will, how is that helping? Also, is it helping or is it a hindrance?
So it depends on how you look at it and who's developing it. I mean, we have certain AI-based training simulation models, which is absolutely fantastic. I mean, with residents or newer doctors where they don't have enough hands-on experience, you know, that's something which can really help. We have imaging tools. I mean, we're putting literally cameras and ultrasound probes right into the chambers of the heart, or you know, into the blood vessels and everything. And AI is making the reading of those results and everything much better. So I feel if used in the right way, AI is probably going to make our lives much more simpler, and is going to make medical technology much better than what it is even today. So I don't really look at it as an hindrance, unless, of course, you know, you don't use it the right way. I mean, you can't just go around asking Google for the silly things, because then it's not
Dr.
right.
Google is pushing it. I know what you're saying. No, fair. But you believe it's going to help. It's going to be a strong part of the technological advancements that happen as we go forward.
I think it's already started to become a part of it. It's already getting a part of it, and it's just going to keep getting better.
Fair enough. Now, Dr. Parikh, let me end this on a slightly philosophical note. Somebody with a healthy heart, or relatively healthy heart, what is that one thing or even two things that they should do so that they can keep it that way for decades? And I do mean decades.
Yeah. The first thing is probably start exercising, move. Move your body. That's the most important. I mean, even a 30-minute exercise in a day, 30 minutes is not much, you know, could significantly reduce the bad outcomes of not exercising. And the second most important thing I would say is kick the butt. Stop smoking. No vapes, no hookah, no smoking. That's for a cardiologist, that's the worst nightmare. You know,
just to be clear, the vapes, the hookahs, all those ancillaries that are there beyond cigarettes, they're as bad, right?
They're equally bad, yes.
There's no such thing as ye thoda better hai.
Nah,
that is not true.
So.
Okay, fair enough. So exercise, even if it's 30 minutes a day minimum, more is better. And no nicotine, basically.
No nicotine, and
in any form.
Of course. With this, if you eat right, if you maintain everything else, like control your blood pressure, your diabetes, all the modifiable risk factors, the things that you can control, try and control those. You know, that's definitely going to add decades to your life.
Fair enough. I have to go back and tell my uncle about the mutton biryani. Dr. Parikh, thank you so much for taking out your time, doing this with us and explaining it to us in layman's terms. I'm feeling more educated and enlightened because I've been able to understand the process, and it's complicated. But thank you for explaining it to us.
Thank you, Jagu, for having me here. Thank you so much.
In the heart of Mumbai stands a name trusted by thousands. Over 1 lakh heart procedures, 200 plus years of combined experience. From diagnosis to recovery, your heart gets complete care under one roof. Because when it comes to your heart, experience isn't optional, it's everything. Zynova Shalby Hospitals. Experience you can trust, care that you deserve.